Hello, Robert Bastian here again, and this is a follow-on to the webinar we did yesterday. I'm just going to try to quickly answer the questions that were submitted, and there are a few more that have come in uh, since that webinar. So here we go. I'm not organizing these. There are a whole bunch of questions, and I'm just going to answer them in the order that they're presented to me here, and I'll probably go a little fast, thinking that you've probably seen the webinar itself and my PowerPoint. So that webinar should have given some of the answers here, but I will go ahead and repeat briefly. So question one, have you had success with 14-year-olds? Did a 7-year-old today, have done 2 prior 9-year-olds, and of course lots of teenagers, and nothing that I know of that's any different for them than anybody else. Went extremely easily this morning with our little 7-year-old. How to get it treated. Number 2, how to get it treated with the NHS. I answered that at the end of the webinar, but my personal approach is to persist in a nice way. I just keep knocking on the door and in a very gentle way, sort of expecting bureaucratic organizations to do the right thing. So I don't know what to say other than that. You just have to kind of, every system in life you have to work through, and I realize the NHS can be difficult. Lots good to say about it, but it's got some bureaucratic roadblocks that could be difficult. Here's number 3. I've had 2 rounds of Botox, definite improvement. I can feel the second one fading. Would I be able to get it done a 3rd time? That's from Sarah. And the answer is there's nothing to stop you from doing it any number of times. Botox is used, of course, for facial cosmesis. We use it in the larynx. The longest patient is about 33 years. I've been doing 3 injections per year. The difference, though, is that when you are treating an actual neurological disorder, you don't expect to ever have a once and done kind of situation. With R-CPD, 4 out of 5 approximately seem to use the Botox as training wheels, and they sort of figure out how to burp. And so we try very hard to do the treatment once and be finished with the disorder for the whole rest of the person's life. But we do have some who recur, and so we've got some twice and done. So we've had some people, not a large number of our 1,000, but who are twice and done. And I think we've got 2 now who are 3 times and done. And there's a fellow from Florida, I think he might be 4 times, and I just don't know whether he finally figured it out after the 4th one, because we can't seem to get a response from him. Question 4. My son suffers from this condition. How many have we treated? She wants hard stats. This is from Susan. She wants hard statistics. How many have you treated? I think we're somewhere around 1,015. How many have improved? Virtually all of them. It's practically universal. I think I mentioned the fellow from New Jersey who had to come back a 2nd time. The first one just didn't work for reasons that I will never understand, but his 2nd injection worked great. So virtually 100% success in validating the diagnosis, giving some weeks or months of relief, and 80% seems to be permanent. They figure out how to burp with the help of Botox. So how many have improved? So it's almost everybody, at least initially. How many have either not been helped, the fellow in New Jersey, or have negative side effects? Well, side effects we dealt with quite fully in the webinar, and so I would just refer you to that PowerPoint. The initial side effects that are a little unpleasant for some, not for all, is excessive burping and that slow swallowing thing that we just kind of get through on the way to a great result. And I think those 2 things happen in highly sensitive. There's a difference in the sensitivity that people have to Botox. There's no way to predict it by age, sex, size. So I think the highly sensitive people may burp excessively, not forever, but just in those first few weeks, and have that slow swallowing problem to a little greater extent than the average. Does this involve vagal dysfunction? Well, originally I thought it was something like that, and I thought of Botox as just a diagnostic test. And I just assumed that everybody, it would wear off like it does when I do it in the larynx or and so forth for a neurological condition of the voice. So I figured that it was just a diagnostic test. And I actually thought initially that people with this problem might mostly need to have a myotomy done because I thought they wouldn't want to do repeated Botox shots. And the reason I don't think it's vagal dysfunction is how would one temporary injection, temporary meaning 2 to 5 months, how would that solve the problem forever when it's been lifelong if it's an actual vagal dysfunction? I think of it more as a sort of an error of response, maybe in a baby or a toddler, where they clamp or they do the wrong thing, and there's just this inappropriate response. And if we can give them the experience of lots of burps, they can sort of figure out the sequence of sensations and fidgets that that you and I do. Those of us who burp normally, we just do it without we're not even aware of the little way that we lower our chin or we lower our larynx or whatever. Question 5, sorry, that was a bit long. Ted asks, are there risks to the Botox treatment? There are early side effects, and then there are those very few complications, nobody in hospital or anything like that. We mentioned it in the PowerPoint, a few with a little minor dental issue, nothing serious. The worst, I think, was the cellulitis and the laryngospasm. Few people have a little early voice change, but it's mostly just side effects. So I don't really think in terms of this being a high risk or any significant risk at all to do this. 6 from Zhao is, how is R-CPD related with other issues like acid reflux? But when you put a block here so that air can't come up, you're going to create, and you swallow air, sometimes in response to the miserable feeling that you need to burp. You're sort of hypersalivating and swallowing more than you might otherwise. Then with this block here, there's a backup all the way down. And so you're going to tend to stretch the esophagus. You're going to damage the lower esophageal sphincter, and that's going to make reflux more likely. Furthermore, your stomach dilates with air, and that creates a lot of upward pressure against the sphincter. And so I think acid reflux is very common in this group of people. And after we relieve the obstruction here and get people burping, some of them have increased acid reflux for a few weeks. And I think it's because the pillow of air is partially or completely evacuated. And now the liquid acidic contents of the stomach can come a little higher in the esophagus. So not infrequently, people will say my heartburn is worse or my reflux is worse. I'm burping great. I feel so much better. I'm not bloated. The flatulence is basically diminished greatly, but I got more heartburn. And we say just increase your Prilosec and wait, and it seems to settle down. And I got some ideas about why that might be. 7, how often do complications with swallowing last after the Botox? Well, I think what this person means is side effects. The excessive burping and the very slow swallowing requiring a little dietary alteration, meaning I have to do smoothies and liquids. That's a small percentage of people who have those to a degree that is sort of off-putting. Many people have a little excessive burping and they just laugh about it, or spontaneous, or kind of at a moment they didn't expect it. But I'm talking about the ones where it almost becomes oppressive. They're burping so much, and that slow swallowing is so much that it's a little bit disturbing. And again, on the way, not permanently, just for the first few weeks. So some people find that for a week or two. The worst I think I've ever had of that slow swallowing that was really troubling is someone that I think in Southern California, it was maybe 6 weeks before she felt that her swallowing had become back to pretty close to normal. But she got a great result and is burping to this day. And that was maybe 2.5, 3 years ago. So all of these excessive side effects occur in a subset, not in everybody who gets this procedure, but in a subset. And it's all temporary, meaning a few days, a week, a few weeks. Would you think that the condition is R-CPD if not all of the four major symptoms are present? Yes. Everybody with R-CPD says they can't burp. They don't necessarily mean they can't ever burp at all, but they can't burp to relieve discomfort. So people will say now and again, I turn my head suddenly and I get this little micro burp, but they can't harness it. Some have said they have never ever burped to their memory in their entire lives. Some say I have burped 4 times in my life and I can tell you where I was and what I was doing all 4 times. So it isn't that but troubling inability to burp is 100%. Everybody has that. The gurgling, there are a few. It's just a small percentage. Almost everybody has that gurgling problem, but there are a few, a small subset, who say the gurgling is mostly internal. They sort of can sense it or feel it, but people around them can't hear it. And some people say you'd have to be really close to hear it, but there are people who say you could hear it across a large room if it's quiet. So you see how there's variation in that gurgling symptom. The bloating is variable in that some people, I would say the great majority, it's abdominal is the focus. The second biggest area is the chest, but when people have the chest pressure, sometimes they experience it as more unpleasant than the abdominal. So the abdominal is kind of a way of life, and our bellies can expand and sort of give us a bit of slack, I guess. Whereas the chest, people say when I have the chest discomfort, it's almost worse than the belly discomfort. And then low neck, meaning people sort of feel it here. So you see there's a little variation of the gurgling and of the bloating. Flatulence is also one where 5-7% of people say, I don't think that's really much of an issue for me. But the question in my mind is whether they are decompressing through the night and they're just not aware of it. Because we've had some people who, the significant other is in the room and the person says, no, I don't think that's really a problem. And the significant other says, oh yeah, but you don't know what's happening when you're sleeping. So there are people who, if you ask on a questionnaire, they'll say it's not much of a problem, but it's really a minority. So overwhelmingly, it's can't burp, gurgling, bloating, 3 potential levels, and flatulence. And the bloating, by the way, often causes either a rock hard stomach, or we use pregnancy as an analogy, and people will say 3 to 6 months at the end of the day. So this person, Paul, still on his question, he says, if you don't have all the 4 symptoms present, he says, I can't burp, gurgling frequently, bloating and flatulence don't feel excessive. Well, there's a continuum of severity of every disorder. So, but, if a person can't burp, that by itself is quite unusual and abnormal if you can't burp. If a person says, I don't really burp, actually, to be honest, when we first started this, I remember at the very beginning thinking to myself, I don't really burp. I'm just not a burper and I'm not in any distress. And then I began paying strict attention, and it turns out we all burp more than we think we do. I'm still not what I would think of as a very significant burper, but I can burp when I need to. And I do burp more than I realize. Number 8, I think we're up to Ashley. What made me think of using Botox as a solution? Well, again, I initially thought of it as a diagnostic test. My hypothesis was that all of the person's tremendous GI symptoms, he'd been to a lot of GI doctors and got no answer. So when I thought about it and heard that he couldn't burp and that he had, I just kind of thought about it and I said, well, we need to figure out if the sphincter is the problem. And so the way to do that is to just put Botox in it. So I thought of it as a test, and that's how it happened. And I am a doctor who does quite a bit with swallowing, and I do myotomies for swallowing trouble. And so I think it set me up. This is a little bit of an orphan area, meaning it's kind of at the bottom of ENT, which is what I am. I'm really just a T doctor, not an ENT, but I mean, I'm an ENT who sort of became a T. But the GI docs, it's kind of at the top of their area of interest. And so it's a little bit of an orphan area. And I think that's because I'm especially interested in that orphan area. I think I was sort of set up to have this idea. Number 9, great to hear of webinar. How do I convince, this is from Richard, how do I convince gastroenterologists this is a real issue? It's getting a little easier because now we've done 4 articles. Dr. Karagama in England has done one. Dr. Snelleman in Amsterdam has done a manometry study. That's one I would probably take to the GI doctors because they, I mean, when I talk to my GI doctors here, for a long time, I just couldn't get any traction with them. I tried, and I mean, they just kind of shrugged and over and over they'd say, "What does manometry show?" And I'd say, "Well, a lot of these people have had manometry and nobody got a diagnosis." But now Dr. Snelleman and his colleagues did this study on 8 people with R-CPD and were able to show the pressure characteristics to underpin or to validate in a different way. I mean, we've got this huge validation of 1,000 patients, but a lot of doctors aren't very interested in that kind of validation. They want a number. They aren't interested in observation and patient experience as much as they are in measurement and numbers. So that would be the thing that might get a GI doctor's attention. Then we go to Caitlin. Research about pregnant women that have R-CPD. Yeah, have significant nausea because of my inability to burp. Yeah, I'm sorry, but we do have quite a few with R-CPD who have talked about how difficult pregnancy was. We've had a couple who said that during pregnancy they could burp. So it's almost like the added pressure maybe overwhelmed the sphincter. But yeah, pregnancy I can see could be pretty unpleasant in this respect. Wonderful event in general, but I'm just talking about from the perspective of inability to burp. Long-term outlook of Botox. Well, again, we have looked at hundreds and hundreds of patients, and it appears that it's somewhere around 80% do one injection. They practice, they sort of learn how to burp, and I'll get to practice. I think somebody asked a question about that later. And they never need another Botox injection. So it's, and our original patient is from, I think it's about 6 years ago, 5 years ago, something like that. I forgot the date of the very original injection. So that was Kevin about long-term outlook. And if we look at the people who are once and done, the median age is younger than the median age of those who need a second or third injection. However, even 40-year-olds and 60-year-olds are more likely to be once and done than they are to recur. So it's still overwhelmingly more likely that you'll only need one injection, even if you're in an older age group. It's just not quite as, and that makes sense because younger people are more plastic, and that's a compliment. Nicole asks, what age do you suggest getting the treatment? She says, I have had this my whole life, and I'm realizing that my 4-year-old son also suffers from this now. He never burps and cries and hits his chest when he has gas bubbles. Well, if you go to YouTube and type something like "my baby can't burp," you will find my YouTube video in which I talk about that whole issue of babies who can't burp. Why, when I'm mostly an adult laryngologist, did I make a video about babies who can't burp? Because when you listen to hundreds and hundreds of stories, you hear some stories of people who say, my infancy, they don't remember it, but what my parents have told me, or sometimes the parent is in the room, my infancy was brutal. They cried, they had colic. Parents say, I never knew a baby could be so gassy. We have parents who say, you know, I would try to get him to burp, and I just had to get used to the idea that he was going to throw up all over my shoulder every time. He never burped, and he just threw up on my shoulder. I even had a set of parents who said, this is a teenage daughter that they accompanied. They said, this is our third daughter. If she had been a third child, if she had been our first child, she would have been our only child, because we just couldn't have gone through that again. It was so that's a subset of people with R-CPD. 2 out of 3, apparently there was no problem in infancy, but 1 out of 3, approximately, there's some trouble in infancy, colic, gassiness, spitting up a lot, and the parents couldn't burp them. So the reason I did that video, sorry, I'm rambling here, but the reason I did that video about babies is I thought somewhere, sometime in the world, there's going to be a parent who's going to stumble across this video, and this parent is involved with a child with an extreme case of R-CPD in infancy. The parents are kind of on the ledge. They're beside themselves. They've been to the pediatrician 10 times, and they, I mean, the baby is unhappy, and it's just an ordeal. And I've said, I understand that people will say, what, Botox in a young one? How dare you even think of such a thing? But when you hear the story of the distress, somewhere with a lot of discussion, and it'll create a lot of angst by the pediatricians, and there will need to be some significant monitoring, and it's going to be a big deal. But sometime in the world, there will be a little one who gets treated for this. Now, why am I in favor of early treatment? Because if you have a 4-year-old, and this can be resolved in a 4-year-old, then that 4-year-old doesn't have to go to high school and feel embarrassed when they're taking a test in a quiet room and they're gurgling and making noise and everybody's looking at them. And, so I would love to find these cases early in life and fix it then. What age? That's anybody's guess. It's going to depend on the degree of distress. So the higher the distress, the more willing we're going to be to do it younger. Certainly a 4-year-old, I think, I did a 7-year-old, a small 7-year-old this morning, and was not a big deal. So that's what I think, but I can just predict that everyone will kind of go, what, you want to do what? But at some point that's going to happen. Now, number 13, haven't been able to burp. Wondering if bloating can occur below the waistline and even the thighs. certainly below the waistline. Again, this is a continuum. Not every case of R-CPD is exactly the same, but they share commonalities. So there is a subset with R-CPD. The majority, it's epigastric. It's kind of right under the ribs. It's the center high and maybe the low chest. This is the area of greatest discomfort. But there is a group. I think there are people who pass the air through very quickly to the colon. They have a very efficient GI tract that just sends it all into the colon. And some of those people have said there's low abdominal discomfort more than this upper. It's a subset, lots of little subsets. Um, does it affect the way you breathe? And the answer is yes, indeed. And we talked about that in the webinar, that when you're full of air and your diaphragms are lifted and you try to take a deep breath and fill, you can't, you just have this feeling that there's no room. I can't take a deep breath. Okay, I'm trying to scan these. This is from Cash. Hopefully more doctors can learn about R-CPD. It's been ruining my life. I get it. Severe daily misery for many people with it. My doctor says this is number 14. I hope this isn't going too long, but I'm just answering questions as they come here. Maybe I'll have to cut this in two if it goes on too long. My doctor says that my lower esophageal sphincter, that's between the esophagus and the stomach, is too loose for the procedure, and that I would end up with too much acid heartburn if they do it. And this is from Hussein, and the answer is, as I said, heartburn and lower esophageal sphincter damage is logically common in R-CPD because of all of that abdominal pressure pushing upwards against that lower sphincter, not per se, but in trying to get the air into the esophagus and out as a burp. So it's backing up and putting a lot of back pressure. And so reflux symptoms are definitely worse. And I wouldn't let that stop me. If you have the big symptoms and if you're really experiencing some misery, meaning can't burp, bloating, gurgling, flatulence. I forgot to mention, it's on the webinar, but the nausea after eating, painful hiccups, that feeling of shortness of breath, even constipation. So if I've got a lot of GI symptoms that go with R-CPD, I wouldn't let reflux stop me because reflux is part of the disorder. And if we're going to improve the mechanics that are accentuating the reflux, we need to get you burping. 15. I received 50 units in March, and the only outcome being miserable acid reflux and no burping. I'd have to know exactly where was the Botox and who did it, and it has, the result is not just dose, but it's placement. So why you would have more reflux and no burping? I'd have to think about that. I'm 6'3", 200 pounds. This is Donovan, 21. It so routinely works that I would just have to wonder placement and dose. I don't know what to answer you on that. Then he says, have you seen improvement in emetophobia? I actually should have mentioned that in the webinar. Emetophobia and sort of general anxiety are rampant in people with R-CPD. Why is that? I think it's because sort of average people, they just kind of live their lives. Somebody says, hey, let's go out for a burger, and they say sure, or whatever. A person with R-CPD, there's a constant calculation to life about, okay, what shall I eat, and what will I say if I start feeling uncomfortable and I have to just eat a quarter of my sandwich and leave the rest? How will I explain that? Or where will I go to release gas? It's just very stressful. It's very hard on social life, and emetophobia is quite big. We have a number of people who've actually had formal therapy for their emetophobia. And you say, well, why would that be? And speculation, as you can tell, I'm good at speculation. My speculation is that perhaps that person with R-CPD had an experience of inability to vomit. I don't think I mentioned that on the seminar either, that because you have to let the sphincter go to vomit, you can imagine that there are people with R-CPD who not only can't burp, but they can't vomit. Small subset can't vomit at all. Very large group have a hard time vomiting, meaning it's a heroic thing. It's an incredible Hulk kind of effort that's required. Well, if you take a little 2-year-old who gets a gastroenteritis and they heave and heave and heave until they can't vomit, or it's this horrendous, effortful, painful thing, well, that 2-year-old would understandably think of vomiting as an extraordinarily aversive thing. So that's my speculation about why is emetophobia so common. It's because it's really hard to vomit in the majority. The ones who can vomit pretty easily, pretty normally, are by the way, much more likely to be air vomiters, where they gag themselves to air vomit in order to relieve symptoms. And of course, they're going to tend to not have emetophobia because emetophobics wouldn't ever do that. Now, 16, what percentage of your patients who undergo the Botox have successful outcomes? Repeating, about 80%. And how long will the successful procedures last? Jets from James. If we get to 6 months and are still burping, we generally say to our patients, looks like you're once and done. There are some people who get out 2.5 months and then they start to get a little bit stressed because it's not quite as easy to burp. And so we redouble the practicing and then we kind of still get a once and done benefit. There are some people that we consider a success who on a severity scale went from 7 down to 0. And they said, I had no symptoms. I was totally feeling great all the time. And then when we hear from them at 2 years, they'll say, well, I'm at a 3 now, meaning I bloat a little bit or I don't burp quite as easy as I'd like. So we include those as once and done. And once in a while, someone at a long interval will come back. I had a young woman, I did her at 9, and she went through puberty. And for some reason, she had been burping great for 2 years or 3 years. And she lost the ability. And so I just did her a second time. So you see, there are a lot of different variations and wrinkles to this disorder. But now, what about, can having Botox procedure damage your vocal cords, affect your ability to sing or speak? Only temporarily at the most. It's uncommon. Since I've reduced the volume of the Botox, I dilute it less. I've had fewer. I never did have, but what was it? 1 of 50 people say, my voice is altered. I've heard a couple on the phone and I couldn't really tell much of anything, but they say, yeah, my voice is lacking a little bit of strength and power. So we've had a few like that, but nobody with a permanent voice change. If the Botox doesn't last the first time, is there a good chance? Yes, we have some second and twice and done. We have some 3 and done. I think just 2, 3 and done. And again, that 4, I don't know. Why do some people not have the ability to burp? Here's a big speculation. Because of the once and done phenomenon, it's caused me to think this isn't neurological or anatomic. My speculation is that there is a percentage of human beings who, when they are either infants or toddlers or very early beyond their memory, they feel the series of sensations that lead up to a burp and they do the wrong thing. They don't know that they're doing the wrong thing, but they clamp or they don't respond in some sort of way, and then it just becomes sort of a repeated experience. And so I think it's that, because otherwise, how would you explain someone being 21 years old, they've never burped in their whole life, You inject Botox once in the sphincter muscle, the Botox is definitively gone in about 4 months, and yet they continue to burp. That's why when people start to burp, we say, please sort of be mindful of the series of sensations and start what I call fidgeting the burps. So in other words, we have a Botox burps have to transition to Kenny burps. This is Kenny's question. So we've got to get Botox burps over to Kenny burps. And so we work on the Botox burps and turn and tuck our chin and lower the larynx, kind of like Bullwinkle, when Bullwinkle had this kind of a voice, or when you yawn. Oh, so you do all sorts of fidgets and see if you can deliver the burp a little faster or bigger or louder. And that's the thing we're going to keep working and as we try to work our way from Botox burps to Kenny burps. 18, scheduled to have the Botox procedure done in September. And I'm wondering what the best steps are, to make them last. Well, just what I said. So I say to people, here's my practice speech. I say, you're going to get your Botox burps. If you do nothing, you're just along for the ride. They're going to happen. After you've had quite a few of them, you'll start to recognize a little bit of a pattern. Okay, I feel that little gurgle. I maybe hear a little gurgle, and I can predict based on the 50 spontaneous burps I've had, they're pure Botox burps. I can predict that I'm going to burp in about 3 seconds. What can I do that will make it happen in 2 seconds? And again, head turn, chin tuck, thrust the chin, look up, and a big one is lower the larynx, again, like you're yawning. Then I say, if you did nothing and you just let the Botox do all the burping for you, maybe you'll have 1,000 burps before the Botox is worn off, if we include all the little micro burps at the beginning. So what I want you to do is see if you can get to 2,000 burps. So I say, certainly when you get to 5 to 10 burps a day or less, be sure that you practice with carbonation. So you get home from school or from work, you sit down with your can of sparkling water, you drink a quart of it and burp it back up, burp the carbonation back up. You drink another part of the can, you burp it back up. So you're trying to burp until you just, burping is something that is second nature to you. So that's the idea of making it more likely that you'll be once and done. 19 is, what is the scope for? Well, it's really just a little add-on to the office examination. So when I see people for this, I of course want to talk to them. I want to hear their story. I want to see how well they match. I want to know, do they have the big four? What's the sort of magnitude of each of the big four? What about the burp? What about the nausea? What about the hiccups? All that. So I want to get all of that. Then I want to look, because I want to see their jaw anatomy. I want to just make sure there's nothing that's going to surprise me in the operating room the next day in their throat. And I'm there. I initially began doing swallowing studies, and I still do those because I thought initially there was probably something wrong with these people. And so I would do these swallow studies to see, can I detect anything at all going on with their swallowing? And the answer is no. They're a slice of the general population with respect to swallowing. So it's not like that nobody could have a little swallowing issue, but that's the same if I take 1,000 people who don't have R-CPD, it would be the same. So then, because I'm there, I can just quickly dive into the esophagus, and I find all these very interesting findings. So I've now seen a pattern of what, and so it's kind of confirmatory. Do I think of it as being essential? No. So if I have somebody with what I call inner claustrophobia, that's my term. We all know what claustrophobia is, the MRI scanner, but I think some people have inner claustrophobia, where the idea of something going in is just, just like people have phobias of needles and of dogs and of vomiting and everything. Why wouldn't there be people who have kind of an inner claustrophobia? So I'm very quick to say, no problem. We'll just, I do want a simple look, but I don't insist upon the whole thing. But that's what it's about. And the findings are fascinating, and the patients always find it interesting to kind of understand. It gives them a picture of what's going on because they see their stretched esophagus. And it's routine. It's basically everyone. It doesn't matter what time of day or the age, you just see this open esophagus. Number 20, I think we might stop after number 20, and we'll have to do a part 2 because I'm afraid I'm going to wear you all out. Number 20 is, I'm curious, this is from Mandy, what is normal as Botox starts to wear off? What is normal? The commonest is that people find they're just not burping as frequently as they were. They're having fewer of those spontaneous burps where they clear their throat and they burp at the same time. And sometimes there's this little downturn where the person says it's almost gotten a little hard to burp at times. And once in a while we get a call, a worried call, and we can often bring people out of that by just reassuring them. And oh, by the way, back to practicing, I forgot to say one thing, that when you are trying to fiddle with the burps, it's not a, I'm going to force this to happen kind of a thing. It's a little more zen than that. Or how would I say that? It's sort of like, okay, fine, exert yourself here if you like, abdomen, kind of push a little bit to try to get it out, but the throat must remain limp and calm. So it's sort of like I can do that. I can kind of go limp in my throat and push with my belly at the same time. So I have noticed that when people, are overachievers and they're kind of trying to punch it out, that can be counterproductive. So again, back to the question, usually what happens is people just notice they're not burping as frequently, and they may have this little downturn a day or a part of a day when it's like, oh, it's like they got stuck, and then they're fine for some days or weeks. And so anyway, that's what the normal is. And when people start to find a little more trouble burping, it can be as little as a month. It's probably most commonly at 2.5 months, 2.5 months, that they definitely notice that it's not as spontaneous. It needs to be a little bit more helped in the way that they figured works. And again, if a person is still burping at 6 months, we consider that's really definitive that they're going to burp forever. That's 20 questions. So I think we'll probably label this Q&A part 1, and then I'll do another one just again so we don't wear you out. Thanks for tuning in, and happy burping. Bye-bye.